Joining me next is Dr. Rajeev. Dr. Rajeev Jayadevan is the epidemiologist, author and co-chairman of the National IMA COVID Task Force and also the past president of the Indian Medical Association in Cochin. Thank you so much for your time. Dr. Rajeev, my first question is that in West Bengal, we had seen Nipah about 10 years ago. And then there were no cases reported in West Bengal. We largely saw cases in Kerala. This time it's come back in West Bengal, and while we are constantly talking about two nurses, it has to come through a human source, right? Somebody infected with Nipah who could not be detected was in that hospital and gave it to the two nurses. Are we missing something in surveillance here to ensure and get to that zero patient, the first patient?
Very good question. Since we've already covered the basics, I'll go directly to answer your question. Did the nurse pick the virus up from another person? It's entirely possible. We do not have a proof of that. But for our viewers, as they would have probably heard, the virus freely circulates in certain types of fruit bats, not all bats. And in areas where bats and human beings coexist, or they live together, or they come into contact directly or indirectly, the virus gets a chance to jump onto man. And as you mentioned, the virus, once it infects man, it can spread to other people. And that is what makes Nipah dangerous, particularly from a community health standpoint. So where the first patient was, and that is really called a primary case, the first case. And commonly, because it is so serious and so severe, the first patient commonly is already dead by the time the outbreak is identified. We talked about the Siliguri outbreak 25 years ago in West Bengal, where a large number of people died, and the diagnosis was made in retrospect. It was initially suspected to be something else. A very large number of people died, and many of them were in fact relatives or close relatives or people who visited patients and healthcare workers who passed away. So clearly it has the ability to spread within hospitals. And the Siliguri outbreak is also remarkable that it started in one hospital and spread to 3 others, which means that 4 hospitals in total were involved in that outbreak. And with a mortality in the range of 70 to 74%. So back to our question here, yes, it is quite possible that a patient who got the virus from the bat, one way or the other, may have come to the hospital, and the nurse may have looked after the person and may have picked up the virus from that person. So it's entirely possible. We don't have proof of that. So, so that is the reason why such measures are needed to contain the outbreak.
Yeah, and this is the worrying part, because if the patient, I'm sure, had family, they were in touch as well. So this is why surveillance gets like really, really important in these cases. However, WHO was very early in sounding the alarm on this one, and they did go on to ensure that some 175 people were tested after that, over 175 if I'm getting the number correct, and all of them have come clear so far, which is good news. But there's a question that always bugs me, Dr. Rajeev. Why are all these viruses found in Kerala? I have never understood. Is it the climate? Is it better surveillance? How is it that the genesis of all different peculiar viruses, it all comes from Kerala or now West Bengal as well?
There are many reasons for this. First, a patient with Nipah does not come with a label, I have Nipah. Someone's got to discover it. Someone's got to find it. And that requires clinical suspicion, the ability to perform a test, the ability to report and confirm it with the reference laboratory in the country. So Kerala, with its prior experience with several outbreaks, it is able to pick up outbreaks at a very early stage and contain it before it spreads to other people. And the way it's contained is, as you mentioned, the contact list of the person is made. And each of these individuals are screened by questions and isolated if necessary, so that they do not get a chance to spread to other people. And after the period of isolation, as long as they remain healthy, they're free to leave. So that's how outbreaks are contained. So diagnostic acumen is what we call it. I'll put this in perspective. Nipah is one of several causes of what's called encephalitis. Encephalitis is In plain English, it's brain infection. It's a very serious illness, brain infection. And brain infection is caused by several viruses. And Nipah is one of the rare causes of encephalitis. So not all instances of encephalitis do doctors send all the tests for all the viruses. So for instance, if there's a Nipah outbreak in the region, doctors tend to spend time and effort in identifying Nipah as well. But otherwise, it's futile to test for Nipah for every case of suspected brain infection. So that's really the reason why Kerala in particular has reported Nipah in the past. Second is Kerala is a travel hub because a lot of people who work outside the state, in the rest of the country, as well as abroad. So whatever infections are from, say, from the Middle East or